So I'm going to do an overview of prenatal diagnosis this morning, and then at the end of my talk, I'm going to talk about something that's new and exciting, therapeutic RNA interference technology, and that's primarily for EB simplex. So this is a picture of a fetoscope, and that was the very first thing that was used for fetal skin biopsy. And this is a procedure that's very, very rarely done nowadays. This is where we would look through the fetoscope and then do a biopsy through the fetoscope. Initially, they were done blindly, but when ultrasound became available, that helped guide the biopsies better. And this gave us tissue to look at the histologies of the skin. And here's one of those early tissue specimens, and you can see that this was a diagnosis of junctional EB. The cleavage plane is through the junction with the epidermis on top. And this fetal skin biopsy is rarely done today. It is still done rarely for reasons that Dr. Cristiano talked about, and that is that a lot of the mutations in EB are personalized family mutations. And so whereas the majority of them can be characterized now by DNA sequencing, some of them still can't. And so this would be a way to still have prenatal diagnosis in those families where the DNA sequence was not known. The risk of this is a little bit higher than other types of prenatal diagnosis. And basically this procedure has largely been superseded by DNA-based prenatal diagnosis, which is what we've been hearing about this morning. And so I'll discuss invasive DNA-based prenatal diagnosis. And the techniques are amniocentesis, chorionic villus sampling, and preimplantation genetic diagnosis, which we heard a little bit about last night. But before I go into the techniques, I just want to say that there is a prerequisite for prenatal diagnosis, and that is before conception occurs, it's really important to have the gene characterized by DNA sequencing. So one way to do this is after the birth of an effective child, after your immunomapping, it's probably a good idea to send for DNA sequencing at that time. Just from a practical point of view, insurance usually, it's a very expensive test and it can cost up to $6,000, and insurance often covers while a child is still in the hospital. So that would be a good time to do it. It's a way to characterize the mutation in an affected child, and then at the same time, parents can then be done. It can take up to 3 months to characterize the new mutation. Once you know where it is, then you can look for it quickly. But if you do become pregnant and you go in and ask for prenatal diagnosis, it may be too late to do this sequencing. So it's best to do it beforehand. You also want to exclude situations such as new mutations, non-paternity, and uniparental disomy, which Dr. Paller already talked about, so I'll skip over that. So amniocentesis takes place at about 15 to 20 weeks. It's a pretty common procedure, and it's actually in these days, it's very low risk. One of my residents just had it and said that at one of the hospitals in New York, the risk is less than 1 in 1,000. Basically, what happens is the needle is inserted and skin cells from the fetus are shed into the amniotic fluid, and that gives you a source of fetal DNA in order to do prenatal diagnosis. Chorionic villus sampling can be done by transabdominal or transcervical approach. And you can see over here, this is the chorionic villi. They're derived from the fetal part of the placenta. And this is done, the main advantage of this over amniocentesis is that this is done in the first trimester. And you do it usually between 10 and 12 weeks, also done under ultrasound guidance. And with this, the risk of miscarriage is about 1 in 400, and the transabdominal CVS is now approaching the same risk as amniocentesis. But again, it's operator dependent, so it really depends on the experience of the person who's doing the test. So you may want to go to somebody who's done a lot of these tests. And then we heard about preimplantation genetic diagnosis last night, and how this differs from the more traditional forms of prenatal diagnosis is this is an option for couples at risk of transmitting a severe genetic disorder. And basically the embryos are tested for the disorder before the pregnancy is established. So it actually obviates the need to do a therapeutic abortion. You would only be implanting in normal embryos and into the uterus. So the indications would be single gene disorders such as EB, and they can also check at the same time for chromosomal disorders. And as was mentioned last night, you can also do HLA testing at the same time. So this has been done in some of the more severe forms of EB. And I'll just go quickly here, but basically the outer membrane is disrupted, a single cell is removed, and it's removed, it doesn't disturb the development of the rest of the embryo. And then, as Dr. Paller described, PCR is used to amplify the genetic material. In the other methods, CVS and amniocentesis, there's a lot of DNA that's gotten, but here you're only doing one cell, and you're doing a lot of different tests with that one cell. So you must amplify the DNA. And then you can also, again, detect other chromosome abnormalities, reimplant the healthy embryo. The advantage, as I said, it eliminates the need to terminate an affected fetus. The disadvantage is this is a very, very expensive test. It can cost over $15,000. You're basically using IV in vitro fertilization techniques, and then you're also doing intracytoplasmic sperm injection, which is another ICSI, which was also discussed last night, and that's another procedure. And also there is a low rate of completed pregnancies, and there's a limited availability to do this. It's not available at every single center. There's also some technical considerations. There can be a failure in the DNA amplification. There can be contamination by extraneous DNA, but again, that's prevented by doing the intracytoplasmic sperm injection, where you inject a single sperm into an egg. And then you can have allele dropout, and that can lead to false negatives, where you wouldn't amplify one of the two alleles. So non-invasive techniques are really not done for EB, so I'll skip over that and go to the future. And so one of the non-invasive techniques is free fetal DNA in the maternal circulation. So it turns out that there's DNA floating around free in maternal circulation, and up to 10% of that is derived from the fetus, and it's mainly derived from the placenta. And so if you did a simple blood draw, you can not have any risks of this procedure other than a bruise from the blood draw. But the major problem is that the maternal allele in the fetal DNA will be masked by the maternal sequences in the circulation. And so this procedure is in use today. It's used to detect fetal traits that are absent from the maternal genome. It's been used for detection of sex, for the Y chromosome, for screening of ROGAM or RH. It's also been used for Down syndrome and for paternally inherited fetal alleles. But in fact, just less than 2 months ago, I came home and opened my New York Times, and this was the headline: tests of parents are used to map the gene of a fetus. So with increasing ways to sequence the DNA of a fetus, they were able to do this now. It's been done, and costs are coming down. And in the article, it said that the cost right now is between $20,000 and $50,000 per fetal genome, but that will be coming down, and that they expect these blood tests to be available for single gene disorders such as EB, just by doing a simple blood draw of the mom. So that is the future. And now I want to switch and talk about RNA interference therapy for epidermolysis bullosa simplex. So basically, as we heard earlier, you have keratin, which comes in pairs, and here's the dermal epidermal junction, and this is a basal cell, and the keratin in the basal cell is keratin 5 and keratin 14, and they complement each other. So here you see the keratin 5 and keratin 14, and they come together, and they have a very nice fit. And so what this does is this, many of these keratin 5s and 14s polymerize together in order to form these keratin filaments, and that's what gives the basal cell its strength and its integrity to resist friction and physical stress. What happens when there's a mutation is the keratin 5 and 14 come together, but they don't fit well. And so what that does is it causes the keratin to be weak, and we get blister formation, as Dr. Cristiano showed us in her electron micrograph of that slide. And this is known as dominant negative interference. It's where you have a product of a mutated gene that doesn't allow a good fit between the keratin pair, and it results in destabilization of the cytoskeleton. So the question is there a way that we can prevent the formation of the mutated gene product? And remember, now we're going to go back to Dr. Paller, where she told us that for every gene you get one copy from the mother and one copy from the father. So actually, if I go back to this, I'm showing you here the mutated keratin 14, but in this same cell, half of the keratin 14 that's produced is the normal type. So the question is there a way to get rid of this keratin 14, only leaving behind the normal type? And so that there's this new technology called RNA interference technology, and this is a therapy for dominant negative mutations. And basically what this is it's a selective inhibition of the mutated gene without affecting the normal gene expression. So I'm just going to do a short biology lesson. We're back into the nucleus of the cell. We have our DNA, and the DNA is transcribed into mature RNA. This mature RNA comes out into the cytoplasm and is translated into a protein. So with this technology, basically what happens is that the translation of the mutated gene is stopped and the protein is not produced. So you're just left behind with the good gene. And this is really a form of personalized genetics. And these small molecules, these small inhibitory RNAs, can be designed to specifically target the mutated messenger RNA and prevent their expression. So this is another disorder. It's called Pachyonychia congenita, and it's caused by mutations in keratin. And it results in thickened nails and thickened soles with calluses. And one of the first experiments testing this technology was done in a patient with Pachyonychia congenita, and she basically had a mutation of her keratin 6A. Keratin 6A, again, is a different keratin pair, but it partners with keratin 16. And so our small inhibitory RNA was designed to match her mutation. It was then injected into her right foot, and a control was injected into her left foot. And you can see here that there's really, really nice callus regression. And over here, where a placebo was used, is nothing. And so this was the very first study showing that this technology can work in patients. And this is very exciting. The problem with it was the delivery. So this was injected, and the patient had said that it was just intolerable pain. And so one of the issues with this technology is how to deliver it. But because we're dealing with skin is really amenable to topical therapy. So the thought was to do a topical delivery system, some kind of cream that could be applied on the skin that could be absorbed. And the problem with that is you have to get through the epidermal barrier. And so Dr. Paller, who just spoke, has actually developed a type of topical therapy, and she's using spherical nucleic acids, which you can attach these designer inhibitory RNAs to. And if you look over here, this is collagen 14 in the red is normal, in the green is the mutated, and she's taken these small RNA molecules and put them in this special cream, and lo and behold, you get just the regular normal keratin. I think I said keratin 14 left. So this is really very exciting, and it's a really exciting topical delivery system, and I'll let Dr. Paller, if anybody has any questions, I'll let her take the questions on that. So these are some resources for people if they're interested in doing some research on genetic testing, and I thank you very much for your attention.